I'm going to be talking about multimorbidity. Feel free to interrupt me as I go with questions. Just wave your hands around and I will know that you have a question. Um, and I am also happy to answer questions after this. So, multimorbidity is something we end up talking a lot about in the care of older adults, and certainly has come up quite a bit in Project ECHO because it's complex and common. So I'm going to talk about some of the challenges of multimorbidity, just briefly, and then I'm going to outline a framework that's been put together for approaching multimorbidity, since this is so complicated. All right. So clinical practice guidelines are something that we use on a day-to-day basis in clinical practice, but they often address a single disease state. We have guidelines for diabetes, heart failure, COPD, so really they're just focused on one disease typically. And there are, millions of guidelines. Maybe not millions, but quite a few. But unfortunately, it's more difficult to interpret these for older adults because over half of them have greater than or equal to 3 chronic conditions. So it becomes difficult to sort out what to do. And in addition, these guidelines often don't integrate patient and family caregiver preferences into the guidelines. A lot of times they're focused on clinical outcomes like controlling hemoglobin A1Cs or mortality, reducing mortality or reducing cardiovascular events. And not necessarily integrating in what's most important to patients. And that will change over time, but hasn't met the prime time quite yet. So let's go through a hypothetical case. We have a 79-year-old woman with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, COPD, and all of these are of moderate severity. This is from an article by Dr. Boyd in 2005, and you'll hear more about Dr. Boyd. But let's just map out what her day would look like if we followed all the guidelines. So in this column, you see all of the medications you would have to take if we followed all the individual guidelines for all these different diseases. And on the right, you see all of the different lifestyle modifications she needs to make in order to follow all of the guidelines. And that would include things like dietary changes. So let's just look at what she does in the morning. So 7 o'clock, she takes an inhaler and her alendronate, and she's sure to put her feet up and sit upright while she's putting her feet up, or she's checking her feet and also sitting upright for 30 minutes to take her alendronate. And then she takes a bunch of medications at 8 a.m. and is also doing a low sodium, carefully monitored potassium diet that is low in saturated fat, following the DASH nut diet, following her diabetic diet, and making sure she has plenty of magnesium and calcium. So she's super busy. And this leads to her being on 12 separate medications, 19 doses per day, taken 5 times per day. And this is following the guidelines, which, we're trying to do to take good care of patients, but doesn't become practical when you have so many chronic conditions. So what do we do about this? So Dr. Cynthia Boyd, who wrote that JAMA article really talking about some of the issues that come up with patients with multimorbidity if we don't really think about them as a whole, she has spent her research career really focusing on multimorbidity and put together a task force in conjunction with the American Geriatric Society. And in 2012, they published these guidelines, Guiding Principles for the Care of Older Adults with Multimorbidity, an Approach for Clinicians. And it's really just a roadmap, a way to think about the general approach to those with multimorbidity that we come across often in our clinical practice. And I'm going to spend the rest of the time talking about these guidelines and just explaining some of the aspects of them. So there are 5 domains to these guidelines: patient preferences, interpreting the evidence, prognosis, clinical feasibility, and then optimizing therapies and care plans. And I'll go through each of these in a little bit more detail. And I put on here, I adapted these slides from the Geriatric Review syllabus, and that's one key to success as a clinician educator, is knowing when to use stuff that's really well done already for your own teaching purposes. All right, so these are adapted from the Geriatric Review Syllabus. The multimorbidity guidelines have a great figure in there that go through the general approach to multimorbidity, and I'm going to walk you through that figure that's really central to these guidelines. So when you're seeing someone with multimorbidity, you should inquire about their main concern, as you would normally do, and any additional objectives they have for the visit, and you might have an agenda yourself. And you can decide whether you want to do a complete review of their care plan for all of their conditions, or if you just want to focus in on one. Maybe today we want to really think about diabetes, or maybe today we want to think about COPD. But when you're doing that, you're thinking about it in the context of everything else. Then you think about what are the current medical conditions, just your problem list essentially, just taking a peek at that, thinking about that, and what interventions are being done for these. Thinking about both medications and non-medications, thinking about that right side of that figure I showed you with all of the diet and lifestyle modifications. And also figuring out if there's adherence or comfort with the treatment plan, basically asking the patient, is this working out okay for you? Are you able to follow through with this treatment plan as it's set out? And that makes it easier to make decisions if you know what the patient is and is not doing. Then the rest of this really goes through thinking about what are the patient's preferences. And this is pretty broad, but and I'm going to come back to it, but you're really thinking about what's most important to them, what are their goals for their care, either of this specific condition, and certainly overall for their medical care and for their life. You think about the relevant evidence available regarding important outcomes, which can be tricky, since we are often in a realm of less evidence with multimorbidity. Thinking about prognosis, and that's definitely something to take into consideration before you make treatment decisions. Considering interactions within and among treatments and conditions. So this is where you're really not just focusing in on the diabetes, but thinking about, is what I'm doing for diabetes going to affect the other conditions that are being treated? Weighing the benefits and harms of the components of the treatment plan, communicating with the patient, which we always do and is best practice, and deciding together for and against implementation of the plan. And then after you develop whatever plan you're going to develop, you're going to reassess it at a certain interval. If you're going to deprescribe medications or stop a lifestyle modification that's been done, change the diet, you'll want to check in and see how that's going and see if it helped you get closer to your goals and made things better for the patient. And that's the meat of the guideline. And I'll go through some of the guiding principles. So patient preferences, the first of the 5 elements. The guiding principle here is to elicit and incorporate patient preferences into decision making. Again, the clinical practice guidelines may not address individual preferences. For AFib, they might be thinking about how can we prevent stroke, how can we balance this against the risk of bleeding, but might not think about how do patients feel about going to get their blood drawn or taking another medication, and what do they weigh as more important. Prioritizing patients' preferences for care is really important here, thinking about what's most important to them. An example of this is thinking about whether it's more important for them to live longer, maintain their function and independence, or be comfortable and without symptoms. And that's often a good 3 things to help patients describe to you what's most important to them. You're also going to interpret the evidence, which is hard. You have to recognize the limitations of the evidence base and interpret and apply medical literature specifically to older adults with multimorbidity, meaning a lot of the clinical trials exclude multimorbid older adults, particularly frail multimorbid older adults. So if you look at the studies used to make the guidelines, or the studies looking at statins or different blood pressure medicines or diabetes regimens, it's important to look at who the patient population was. And if it wasn't anything like the patient you have in front of you, it's okay to discuss that you're either in a realm of unknown, or if the patient does fall into that category. But that's an important part of interpreting the evidence, and also helps you support your deprescribing when you're doing it. If, you know, some of the primary prevention trials for statins, for example, weren't really meant for people with multimorbidity who haven't had prior cardiovascular events. And just acknowledging that evidence gaps exist and you're in a realm of uncertainty. Prognosis, you're going to frame all of your management decisions within the context of risk, burdens, benefits, and prognosis. And when thinking about prognosis, you're not just thinking about how long someone's going to live, although that's an important part of it, but also what will their functional status be within that time period, and what is their quality of life within that time period, and what can get us to a higher quality of life or better functional status. So taking all of that into consideration beyond just number of days someone is going to live. And this discussion of prognosis is a really good introduction to some difficult conversations about what the overall plan is for care. Are there any tools that any of you use for prognosis? All right, everyone's chewing their lunches, so I'm going to fill it in. We talked about eprognosis.org as a really good tool to think about prognosis. It's so important to know what the life expectancy is of your patient before you choose a treatment, because you're thinking about that time to horizon of benefit. Does this help in the time frame that my patient has? Clinical feasibility is the next part. You're considering treatment complexity and feasibility. So not just what you're going to do, but what does this mean for the patient's life? How complicated is this? Is this more trouble than it's worth? A complex regimen puts you at higher risk of non-adherence, adverse reactions, impaired quality of life. It hits your pocketbook. Economic burden is definitely a part of it. And then caregiver strain and depression. So the more complicated a regimen is, the more difficult it is for the caregiver. So whenever adding, a diet restriction or medication, thinking about, is this worth the additional burden? Is it really going to help the patient that much more to have 3 times a day metoprolol versus once a day? Is the margin of benefit going to be so great that it's worth them having to have a caregiver give them meds 3 times a day? Optimizing therapies and care plans. So this is, the final part of it, thinking about choosing therapies that maximize benefit, minimize harm, and enhance quality of life. Wow, that's super complicated, one sentence. But that's what you're doing. You're just trying to get the most benefit, help people get to their goals, decrease harm, and make sure they're living as well as possible. Older adults with multimorbidity are at risk for polypharmacy, suboptimal medication use, errors in how they take their meds, and potential harms from lots of different interventions, both medications and non-pharmacologic options. Even something as simple as, a restrictive diet can lead to weight loss in someone who's already having difficulty with their food intake. Reducing number of meds can lower the risk of adverse drug events. So that's one thing you're going to do when you optimize the care plan almost every time, is really looking at the med list and optimizing it. And thinking about non-pharmacologic interventions very carefully, because they may be more burdensome than beneficial if they're inconsistent with someone's preferences. So how important is it for someone to elevate their legs 4 times a day? I don't know. It depends on the situation and how bad their leg swelling is, and if it's causing them discomfort. Diet is a big part of this too. There are some great tools for multimorbidity that you can use since this is so complex. Geriatricscareonline.org, which is the American Geriatric Society repository of everything geriatrics. You can, for free, download the Multimorbidity Toolkit, and it has the original paper and a lot of information on how to apply these guidelines to your clinical practice, and also some cases you can go through. There's also an app for this, like most things. Multiple chronic conditions, MCC Gems, you can find it in the various application stores. and get it for free, and it has a lot of this information about the guidelines for multimorbidity, and you can just take it with you on your smartphone and read it as you go. So in summary, the treatment of older adults with multimorbidity requires a flexible approach because of the heterogeneity among these patients and the inadequacy of most of the clinical practice guidelines. There are 5 domains of evaluating and managing older adults with multimorbidity that I went through. So it's considering patient preferences, interpreting the relevant evidence, considering someone's prognosis, considering clinical feasibility, can they do this, and then optimizing therapies and care plans to really streamline them, to align them with goals and make them as simple as reasonably possible. There's a lot you'll see in the next few years with multimorbidity, certainly over the next decade. Dr. Boyd, who spearheaded these guidelines, is working with various societies who create clinical practice guidelines and is trying to get them to talk to each other and also to talk to patients and caregivers and integrate their input into these guidelines. So I think you will see a shift in the guidelines over the next decade in how they're approached and how they interact with each other, and that's really positive and wonderful. But right now, we're really doing a lot of work on our own to think through how to apply these guidelines to folks with multimorbidity. And this way of thinking about it that Dr. Boyd developed, I think, is very helpful, and I use it myself. All right. Good, we have a blank slide. Good. All right. Any questions or comments before we move on to our wonderful cases?